Good evening, everyone, and welcome to this very special Norwich Science Festival at Home event, The Power of Collaboration. We're just waiting for a few more people to join us and we'll get started.
Good evening, everyone. I'm Dr. Kirsty Cully, and I'm Associate Director of Science Engagement at Norwich Research Park. Thank you for joining us tonight for this special event, for our Norwich Science Festival at Home event. I'll shortly introduce you to our chairperson, Professor Dylan Edwards, who will give you an overview of how our colleagues at the Norwich Research Park have responded to the COVID-19 pandemic, and introduce you to the rest of the panel who continue to lead in this work. But first of all, a little bit of housekeeping. After Dylan has given his presentation and chatted with our panelists about their work, our panel will be taking your questions, which you can post in the YouTube live chat. I hope we'll get to as many questions as possible before we finish at 8 p.m, but please remember that all viewers will be able to see the comments you post in the live chat. Once the event has ended, please do tell us what you thought by filling out our survey with the chance of winning a John Lewis voucher. The survey can be found on the Norwich Science Festival website or by using the link at the slide at the end of this event. To help secure the future of the Norwich Science Festival, please do consider making a donation by visiting norwichsciencefestival.co.uk/donate. Please enjoy the event and do enjoy and join the discussion in the live chat. And now over to Dylan.
Good evening, everybody, and welcome. My name's Dylan Edwards. I'm the Pro-Vice Chancellor for the Faculty of Medicine and Health Sciences. I'm chairing the session tonight, and we're going to talk about, introduce you as well to some of the key people that have played major roles in how we've all come together to fight this important battle against COVID-19. I just would like them to step forward, my fellow panelists here, to say a few hellos, and then I'll give you a short presentation. Then they'll do a bit more from their individual perspectives. So first up on my screen here is Mark Hitchcock.
Nice to see everybody. I'm looking forward to having a chat this evening.
You're a bit faint, Mark, but never mind. Well, hope you'll get louder later on. So Rose. No, you're on mute, Rose.
How's that?
That's better.
There we go. Hello, good evening, everybody, and I look forward to chatting with you.
And Chris?
So, hi, I'm Chris Bowles. I'm a consultant at the hospital. I mainly look after people with blood cancer, and I'll tell you about what the hospital did and how we changed the things we did.
And Justin?
Hi, everybody. Justin O'Grady here. I'm a researcher at the Quadram Institute. I look forward to speaking to you later.
Great, thanks. So I'm going to share my screen now, and let's. I'll start with this presentation then. Where are we here? This one. Okay. Is that now working? Can everybody see this? See my screen? Great, good. So COVID-19 is obviously a very terrible thing that has affected the whole world here, and really it's a major problem that we're facing. But when we face things together, when we can work together and bring individuals and their strengths and organizations and their strengths together, we realize just how much more we can achieve this way. And this is the story of what's been going on here right under our noses in Norwich, on the Norwich Research Park, how these folks that you're meeting tonight have been in the forefront of coming together and achieving some wonderful things in this battle against COVID-19. So to introduce you really, first of all, I want to give you some background on what is the Norwich Research Park? What does it mean? Physically, geographically, it's made up of 6 major anchor organizations. The University of East Anglia is a premier university, as is the Norfolk and Norwich University Hospital, one of the biggest hospitals in the country. And we're also blessed by having 4 of the leading research institutes in the world here on the Research Park: the Earlham Institute, the John Innes Centre, the Quadram Institute, and the Sainsbury Laboratory. And together we cover a spectrum of research, right the way from plants, crops, through to gut health, gut microbiome, right through to human health and healthy aging. And on this wonderful environment with 17,000 students, 3,000 clinicians and scientists, researchers working together, we can really achieve amazing things, and some of that you'll see evidence tonight in the stories that we've each got to tell. I love this picture here, this aerial view, because it highlights how close we all are together, the university and all of these institutes and this major hospital, all on the West Campus site on the Research Park. Here's a little bit more about what the nature of these organizations are. So the John Innes Centre and the Sainsbury Laboratory are really the #1 in the world in their areas of plant research and plant microbe interactions, the organisms that cause diseases in plants and crops. And UEA is itself a top 15 university in the UK, top 200, sorry, whoops, I got better than we were in the world rankings. Norfolk and Norwich Hospital, one of the top 10 in the country as well, in delivering clinical and research, clinical activity and research. And the Earlham Institute is one of only 2 genomics institutes in the UK. and together working in partnership with all of these organizations. Oh, I missed out the Quadram Institute as well, can't do that. The Interdisciplinary Research Center working on food and nutrition and the gut. So these are the anchor organizations, but I should say as well, there's 150 other small to medium enterprises that are here on the Norwich Research Park and all able to work together to achieve great things. This is a bit about background. This is far too much than you need to know about me. Basically, I've been here in Norwich since the last century, and I've known a lot of the organisations, the people here. I've worked in some of them, and since the last 4 years, I've been Pro Vice Chancellor of the Faculty of Medicine and Health Sciences at UEA, which is one of the 4 faculties there. And in that role, I've become the executive chair of one of the key organisations here tonight, UEA Health and Social Care Partners, that Mark Hitchcock's going to tell you a bit about as well. And I've had a significant role in across the research park in helping people to come together. So when the COVID emergency struck way back in March, we saw it coming in February, but really it was the middle of March when all the impacts started to happen. The organizations of the park really got together and worked collaboratively to pool their resources, pool their expertise and knowledge to be able to help each other and to achieve what had to be done and to set off in new directions. So here's a few of the snapshots of the things that we did. So right at the very beginning, early on in the park, people got together and tried to help the NHS out, working to be able to do its job and deliver the care and support that everybody needed. So to help them facilitate that, and a key element of that is this organisation that Mark represents, the UEA Health and Social Care Partners, which is 12 partner organisations across the whole of East Anglia, all of the NHS trusts, the Norfolk County Council, Suffolk County Council are included in there. So NHS as well as the civil organisations. And through having that, we had a network, a ready-made network of being able to link across the region. And so Mark was a pivotal person in really being able to put people together, put the right people together at the right time to be able to make best use of things. And with that, we were able to tackle some of the early problems that the NHS was facing. So shortages of personal protective equipment, making hand sanitizer, these sorts of things, and then leading onwards and helping put the right people together and get the right research. So Mark's going to tell you a bit about his experiences in there. And with this, we were able to mobilize all sorts of activity. We got people and organizations coming together around 3D printing to be able to make PPE equipment, face shields and headbands, and produced 12,000 of those within the science labs over at the University of East Anglia, led by the technicians there, lots of volunteer effort, tons of outside organizations coming together and offering their expertise to be able to achieve these ends. So 12 weeks of work, 14 technicians, 4,000 litres of hand sanitizer. That's an awful lot of ethanol that went into that, and a lot of talking around the region to get people to donate their supplies of anything from brewers and distillers to be able to do this, to be able to generate the hand sanitizer, to generate enough hand sanitizer to clean 2.6 million hands across the region, and then using the network of health and social care partners to be able to get this distributed where it was needed out there at the coalface. So we were able to provide support indirectly for the NHS by providing daycare for the children of NHS staff and for accommodation for NHS staff to be able to, so that they could work and be on the front line and not have to worry about going back to their families and taking potential infections back to them. So we were able to maximize the work that the NHS could do at that time. We were able to mobilize our medical students and nurses and midwives and allied health professionals to get them into the workforce early in many cases, or to get paid placements so that they could work in the NHS. And some of our clinical academic staff at UEA who were who'd stopped doing clinical duties, they were able to retrain and get into the front line themselves, they're doing the frontline NHS work and help out the NHS. And right there on the front lines there, the hospital was changing and adapting as things went. Chris is going to be able to tell you about this. So they created a second emergency department and new intensive care units and trained additional staff to be able to treat with the people who were coming in. And this is then where Rose and Justin come in, particularly because Chris was able to help bring people together to expand the ability of the hospital to carry out COVID-19 testing. As Rose will say in a little bit, she'll be part of that, a major part of that COVID-19 testing area. And since then, NNUH itself has been part of many major national trials, clinical trials, to help tackle the disease and to help find new ways of treating the disease. Part of that results about the effectiveness of dexamethasone, for instance, in treating people with advanced disease, has come from the clinical work that was the clinical trials work that was going on here on the research that NNUH were part of. And understanding how COVID-19 works, how does the virus work? What does it do? How does it affect our body? How can we fight it more effectively? Lots and lots of basic research that has been going on at this level. And this is where Justin's work as well. Oh, and Rose's work too in setting up the dedicated testing lab at in the Bob Champion building, part of the medical school, which has been running 7 days a week since April, carrying out COVID-19 testing that is in support of the NHS. So it's part of what we call Pillar 1 testing, increasing the capacity of NHS testing and providing those testing results within 24 hours. Rose will tell you a bit more about her experiences doing that. And Justin's work has really been part of a national effort called the COVID-19 Genomics UK Consortium, where across 5 months earlier, this is work that's still going on, but this is up to August when the data was gathered here, they had by that time sequenced 50% of all of the sequences that had been published of COVID-19 around the world had been done via this UK consortium. And so Justin's work was one of that key to pulling into that and understanding the different variants. This is what's called genetic epidemiology. So you can do really tracing the origins of diseases and see how it's spreading, how different forms are related to each other. And that Justin directly contributed to understanding the origins of outbreaks in care homes in North Norfolk, and also the Banham poultry outbreak, to show that in fact that wasn't a local the origin to that it had been brought into the country from Portugal in that case. Lots of exciting insights there. But many other sorts of areas of activity have been opened up through this time. Many of you will have seen one of my colleagues, Paul Hunter, who's rarely off the television, frankly. And so Paul and his colleague, Julie Brainard, have done fantastic amounts of work on a range of different activities. The value of face masks, the importance of the impact rather of fake news on COVID-19 information. Many areas of activity that relate to our understanding as a society about COVID-19. We have work from our experts in climate change. Many of you will know that the University of East Anglia is a global leader in climate research, and Corinne LeQuarrie in the Tyndall Centre has been tracking the impact of the lockdown on carbon reductions across that period, and understanding how that's reducing and what the impact is as we move forward, as lockdown has eased up as well. And then as well, some fundamental work that Carl Philpott in the medical school has done has been to actually recognize that loss of sense of smell, actually particularly amongst women in their 30s and 40s, one of the key symptoms now for recognizing COVID-19, that it's actually anosmia, loss of sense of smell. We've had people who've been tracking the health and well-being, the COVID-19 health and well-being survey that's been conducted by Felix Norton and Caitlin Moran and others, looking at the health of 1,000 people across the country, and tracking the impact of the virus on health and well-being. And of course, part of this is that we're increasingly developing our technologies for developing ways to detect the virus and how we can deploy those. We'll hear about the way that the testing that Rose has established over in the Bob Champion building, but there are new tests coming along as well, potentially. This is not really, so this one that we're highlighting here from Rob Field and his colleagues at ICNI Diagnostics is still in development, but it has the potential to revolutionize rapid detection of the virus, picking up not on its genetic sequence, but on its coat protein, so that we can see exactly what it is and do rapid testing on site. And other systems that are being developed from some of the partner companies on the research park. So leaf expression systems specialize in generating large quantities of proteins, and they've done that for one of these coat proteins of the COVID-19 virus, to be able to produce it as an antigen that can then be able to raise vaccines again. So this is going into development here. This is a very complicated side, which I don't frankly completely understand myself, but it's a completely novel way of doing COVID-19 detection using a system called CRISPR-based technology, which those of you who know was what the Nobel Prize was awarded for from Emmanuel Charpentier and Jennifer Doudna a few weeks ago for CRISPR-based technology. This is to apply that technology to make a rapid genetic test to foresee picking up the virus. This is still in development by our colleagues at the Sainsbury Lab, but it has massive potential to revolutionize testing forward. But coming to testing, really, the key area there came from the established tests that had entered into the NHS service that our partner organizations across the research park came together with the notion of being able to deploy this in a way to deliver mass testing at a population level. And this particularly involved the Earlham Institute and the UEA working together very extensively to develop this notion of mass testing. And we ran a pilot in the summer to test the feasibility and the logistics of it all, and tested 3,046 tests on 800 people, and showed that we could do this and get tests out the same day. So that enabled us to go on to the next phase with this testing pilot, to be able to deploy this in earnest, in combat, really, in situation, in testing out the students and staff of UEA at the start of the new academic year. So this is now what we're calling the Norwich Testing Initiative Phase 2. And the aim is really to identify cases of virus, people who are carrying the virus at an early stage. They're asymptomatic, they're potentially spreading the virus, so you can encourage those people into isolation and prevent the spread of the virus to the wider community and out to the people of Norwich. And this is work that's ongoing right now. So really, this is where we are at the present time. These are my colleagues, have all taken different roles and different aspects of that background that I've just given to you here. They've all had major contributions to make, and they'll be able to tell you some of how this has impacted their lives and what they see of how things have changed and where things are going for the future. So I'm going to I'm going to stop the presentation at this point. So I'll stop sharing my screen as well, if I can. So let's do that. Stop share. Okay, so that's stopped sharing. And we're going to go over, first of all, I think, to it's Rose Davidson, who's first up to give her view of things.
Thanks very much, Dylan. Good evening, everybody. So I am a researcher who is based at the University of East Anglia. And just before lockdown, I was very, very lucky to have been appointed as a new post as a lecturer in nutrition and biomedicine within the Norwich Medical School. And During lockdown and up until now, my role really has been in trying to provide extra capacity to our local university hospital in terms of COVID testing. And I guess the reason why I got involved is because I have a long history of working with a technology called qPCR. And qPCR is the current gold standard for measuring COVID-19 in clinical samples. And we have this kind of technology at the university at our disposal, and it seemed to make sense to make this available to our partners on the NRP, particularly the hospital. And so we worked very closely with the hospital to bring the test online, and we've continued to do so ever since. So we, as Dylan alluded to, we test samples 7 days a week, and we aim to always get those samples done in under 24 hours. We usually end up doing it in under 15 hours, which we're very proud of. And we really do hope to continue to do so. I think you're on mute, Dylan.
Okay, so we'll let everybody have a say, and then come back and ask questions about how we go forward, how you see things moving in the future. Let's go to Mark now for his take on things. Tell us about your life, Mark.
Can you hear me clearly enough now?
Yeah, that's better. Yeah.
Great. So I suppose before March, I was busy running between organisations in the NHS and the University, Norfolk and Suffolk, trying to connect people, just trying to make things easier for researchers and clinicians to work together to do more research. And we were researching in every area, apart from COVID, I would have said. And it was going very well. And we worked in a normal office, and we did an awful lot of commuting, and everything was fine. And so since March, everything's changed. There's an awful lot of web meetings, although we still leave our mics on mute. So we've got an awful lot of experience of sitting staring at screens, and actually I think we're busier now. And the drain on your sanity and also your time at home is tricky. So we've had to get used to working at home, I think, all of us to some degree. But apart from a couple of days when we started lockdown and I started to get the anxiety everybody else enjoyed, starting to count baked bean tins and toilet rolls, I had a chance really just to reflect on what the partnership could do to help most of our partners that were giving those services at the front line, both in hospitals but also in communities and social care as well. And so we put a very small but very good team to work trying to manage projects that were needed. So our partners knew where we were. They started speaking to us. We started asking them what we could do. And we started connecting them up then with people around the park and also with commercial partners and charities in the region and around the country in some cases. Some of those projects you mentioned, we were able to help bring people together to solve. We rarely did too much ourselves, but it was about making sure that the link was there for people to be able to collaborate effectively. And probably about 2 days in, after that anxiety had left me, it felt really great to be purposeful. We've always making a difference, which is great, but actually we were dealing with a range of different people from around the country, different sectors, and everybody was motivated to make a difference. So since March, it's been crazy. They've been very long days. There's been an awful lot of days of work, but actually I think we've been motivated just because we believe we're making a difference. And so it's a great reason to come together. And it's been one of the most enjoyable times of my career, frankly.
Great. Shall we? We've got questions coming in already, but we'll go over first to Justin and then to Chris, and then we'll pick up on some of these questions. Justin.
Okay, so hi everyone. I'm Justin O'Grady. I'm a researcher at the Quadram Institute here on the NRP. And well, what I used to do, I used to travel the world a lot, but that's certainly stopped in the last few months. Probably good for the CO2 emissions, of course. I'm at least one of those 17% reduction. I think I used to work on the rapid diagnosis of infection. I still do, that hasn't changed. So I tried to diagnose in pathogens in human clinical samples. But I used to focus on bacteria and fungi and not really viruses. And certainly that's changed. So I used to work on things like tuberculosis and pneumonia and sepsis, things that you might say I've heard of, things that people get in hospitals or get in the community. So, and then when the coronavirus came along, of course, my skill set was quite useful. So I started to reapply myself to coronavirus while trying to keep working on all those other things at the same time. And coronavirus has added a big chunk of work onto what I was doing. And, you just have to find some additional time just to fit it all in. But it's been a very, very busy time. But luckily, a lot of the skills I had were useful. And then what I needed to learn some new things, so I did. But I'm still not a virologist. I'm still not an expert in virology, but I know some stuff. So we've been applying our expertise to sequencing the virus and trying to track and trace it. And that's I must be taking up at least half of my time at this stage. So that's it, really.
Okay, let's bring in Chris for your perspective.
So my name is Chris Bowles. I'm a doctor at the hospital. My job is to look after people with diseases of the blood, mainly blood cancer like leukemia, lymphoma, myeloma. And I'm part of a team, a big team. There's about 7,000 or 8,000 staff in our team at the Norwich Hospital and the Cromer Hospital. And I'm also part of the wider team of about 1.5 million people that works for the NHS. And I can't speak for everyone, but pretty much everything changed in my life. And I think it's probably true for most of my colleagues. And of course, we wanted to sort of provide a service to look after and protect our patients, their families, carers, friends, but also we needed to look after our staff and our colleagues. And we had to sort of set up a COVID hospital to support our community, but also because of the size of our hospital to support sort of perhaps other hospitals more widely. And at the same time as doing that, of course, we had what we call business as usual to get on with. So leukemia didn't go away, blood cancer didn't go away, diabetes, asthma, epilepsy, all those things still happen. And we still had to sort of provide a service for that. And at the same time, protect those people coming to the hospital for those reasons from the virus itself. So we got really busy and we changed an awful lot. In fact, as I said, almost everything. So we changed the way we interacted with a lot of people. So we sort of kept in touch with people where we could by phone or by video link. We did a lot of the things that we usually do in the hospital, like dispense medicines. The pharmacy got really busy and started delivering medicines to people at home. And we knew that early on there'd be people that were going to be really vulnerable to this. So take people having cancer, treatment, chemotherapy. So early on, we took the site at the Spire Hospital in Watton Road, and we're able to use that for our chemotherapy service and keep that as free and clean. In fact, we managed to keep it COVID-free throughout the whole of wave one. And we knew that there was surgery that was particularly, I mean, all surgery is important, but particularly cancer surgery was important to keep up with. And we're able to keep that going by doing a lot of that surgery work down at the other site. Simple things like the way we dressed changed, the way we ate changed. In fact, we used to shower before leaving work. We had to significantly increase our capacity to look after the critically ill person, the person that could no longer sort of breathe for themselves without support. And my colleagues in theatres and intensive care and anaesthetics had to do a huge amount to increase our ability to deal with that. And then we needed to we really thought early on we needed to separate patients that we knew didn't have COVID and look after those in a particular part of the hospital, and cohort and group together patients that did have COVID and look after those in a particular part of the hospital. And we thought that was going to be key. And really, that could not have been done without the extra capacity and the testing and the diagnostics that Rose and Justin and Dylan and others, actually many others, they'll tell you, but Rose and Dylan and Justin led in terms of developing for us, because it was, it felt a lot of the time we were behind the virus, behind the curve. Things like PPE, it felt, from a standing start, we were behind that. But it felt right early on for us that there would never be enough testing, and therefore the more that we could get and the more we could understand who had what when, then the easier it was going to be for us to manage all the people that we look after, both as an inpatient as an outpatient. And I was reflecting today, knew that I was going to come and have to speak about this. And I've known Dylan for years, and when we realised that testing was going to be key for us, and that we perhaps weren't going to get enough from the places where we normally send testing to, I emailed Dylan and said, "Can I speak to you on the phone?" And he got back to me within half an hour. Within 3 hours, we had all the leaders of the institutes that you've just been told about on the phone. Rose was engaged, and within days we had hundreds of volunteers that stopped what they were doing and helped us. And to be honest, the 8,000 staff here did an incredible job, but it was, fundamentally supported by the extra support that we got from the research park, which helped us to navigate through what was an extremely difficult and challenging time in wave one. And I think puts us in a better position as we look at going into wave two. So I've lost track of the number of times I've said thank you to the people on this call, but we're really grateful for their support.
That's great, Chris. And thank you so much for those words. They're really good. Some of the things that I'm struck by from what Justin and Rose in particular have said is that that they end up doing things that what COVID has initiated people to do, things that they're not part of their usual, their previous way of thinking about things. Rose, you were a researcher in arthritis, but you knew how to do qPCR, and yes, you stepped forward to apply it in this context of COVID diagnostics. And likewise, Justin, your area is bugs and bug diagnostics, bacterial diagnostics, but here this is a very different challenge here, and also then getting into this whole field of epidemiology. So I think part of the message that's coming from me is the ability to be versatile and to think and to be able to see an opportunity and to move into it, and to be open-spirited in that way. What would you think?
Yes, I would agree with you, Dylan. I must admit, my life has completely changed. Before lockdown, I was very much, a research scientist working solely on osteoarthritis or musculoskeletal diseases, where I spent all day thinking about how our diet could affect the health of our joints, essentially, and which, I still think about quite a lot. But fundamentally, the techniques that we use to do that kind of research can be applied to a variety of diseases, and in this case it seems like a great opportunity to use the expertise that we had on the park to come forward and see if there was something else we could do to contribute, because I found it very difficult. I think, like Mark said, I think I found it quite difficult to come to terms with staying at home. And I felt quite strongly that there would be something that we could do, and we have all this incredible expertise on the park and the technology there, and I was just really, really pleased to be able to contribute in a small way.
Yeah, I think it's versatility is certainly useful in these difficult times. So I think we started working on genomic epidemiology, something I certainly am not an expert in. And, we had to learn quickly, and we had to work very collaboratively and work with experts in the field and learn from them. And, when we started working on this genome sequencing project, which started really as a research project led by Cambridge, you know, we expected it to, you know, to be a research project and to behave in a certain way, but then it's turned into really a service for the government. So now we're providing genomic sequencing and as much genomic coverage as we can get of the virus across the whole country through a network of collaborators across the country, and then to provide this sequence information and to analyze it and to determine what's happening, how the virus is spreading, to help stop outbreaks, to help control the virus, and to know how it's come into a place, whether one person has transmitted it to the other or not, these kind of questions. And this genomic sequencing and genomic epidemiology has allowed us to do that. And as I say, that's a whole new area for me. But now we're, you know, from being a researcher in an institute doing, you know, being an academic, shall we say, to now providing a kind of a service for the government in a pandemic is quite a change.
We've got a number of questions that are coming in from the public. I don't want to stifle anybody else's comments, but some of them actually, I think you might have answered this one from Rachel about why is sequencing the virus important? How does it help? I mean, Justin, do you want to expand on anything more about that? How does it help actually? Yeah,
I'll try and give a kind of a brief explanation of what we try to do. So when a virus replicates, it can make a mistake in the sequence of its genome when it's making a new genome, and it makes about 2 of those mistakes every month, this particular virus. And so these mutations in this genome, this viral genome, is about 30,000 letters long. And it'll make a mistake every so often, as I say, and this mistake then is passed on to the next virus and the next virus. And so different viruses in different people make different mistakes. And so we can make these kind of family trees of the virus. And so we can tell then when I have a certain type of the virus and it's come from, say, my mother or my uncle or whatever, whoever I got it from, and then somebody in China has a different type of the virus, they got it from their family member, they will be quite different. They will have about 10 or 20 letter differences between them. So this effectively boils down to being able to tell the difference between who gave the virus to who and who didn't. So the virus I got from somebody will be almost the same, whereas the virus, if I didn't get the virus from somebody, it would be quite different. And we can tell that from the genome sequence. So that's what we do. And so what we'll do is we'll go into, imagine 5 people in a factory have tested positive, and we will sequence all their genomes from those positive tests, and they'll either all be very similar genomes or they'll be different. If they're similar, we'll say, yes, this is an outbreak. And if they're all different, we'll say, no, all those different people must have picked it up in the community, not in the factory. So that's what we use the genome sequence for.
That's great. There's some other ones coming into. This one is really, so I'm filtering them across to different panel members here. So this one might be more for Chris and for Mark to comment on. What sort of things have the NRP done around supporting staff in terms of mental health and balancing other life disruptions that remote working can often lead to? Anybody want to have a crack at that?
So you know, as I said, amongst the 8,000 people that work in our organisation, my job primarily is to look after people with blood cancer. But I can honestly say I feel well supported in my organisation. I think it's been a strong narrative from the people that have been managing this, specifically going out of their way to say that they're interested and they care for the staff. A number of the way that we work's really changed. There's, you know, people have been encouraged to, where possible, for example, to work from home, and there may be some medical reasons why that's necessary, or it may just be a case of reducing the chances of catching this. And I know that you know, we have our own health and healthcare service for the staff within the organisation. I know they've been really busy because it, to be honest, it has been hard, and it has been long and the hours have been hard, and we've seen some really sad things. And a lot of us that have been in healthcare for a very long time, have found ways to manage that, but it has been on a really different scale. And at the same time, we've been seeing what's been happening elsewhere in the country and elsewhere in the world. We can see that lots of people in healthcare have been struggling with this. So yeah, I think the organisation has taken it really seriously and has tried to adapt our lives and support us as we go through this, really difficult time.
And then maybe I could say a few things from the UEA side, and maybe from the UEA Health and Social Care side as well. I mean, I think all the employers on the park really responded quite quickly, and have been very supportive actually from the home working side. I think it's fair to say that we're still trying to understand what that means, both as individuals and also as employers, and how long that will go on for. We've just recently, again at UEA, extended home working for another quarter. So I think we're still understanding that to a degree, and the longer term mental health and well-being concerns that Mike is touching on there are really important. We've all got the support in place, and I think we're quite supportive community anyway, but there is work ongoing within the health partnership looking at the impact of sort of difficult decision making, particularly on clinicians in various sections of the NHS through moral harm studies. And some understanding about the impact or the increased stress levels, particularly again amongst the NHS staff, and how that's being handled through the Workforce Sustainability Research Group. The testing, I think, has helped to reduce anxiety. We had a huge uptake in the first stage in July, August across the park, and we're about to extend that out to the other park parties as well, to add to the UEA testing that we've been doing over the last 6 weeks. So I think I've been really struck when I've been in centre there, seeing people pick up their kits when they've talked to us about the difference it makes them in relieving their anxiety. And so there's a number of different ways I think that we can help people. And we're also trying to make sure that we keep spreading our knowledge around particularly psychology and well-being on the broader picture as well. So it's important to note that the Future Learn module out there for managing anxiety in children during COVID-19 is still available for free. Has been taken up across the world, 130 different countries using it. So we'd like to do more of that to make sure that not just the park, but also our region and beyond are getting some support in terms of getting through this period as well.
That's great, thank you. So I'm going to go back to a question that came in initially from Michael Pemulis from the US, who's made a comment that he believes the responses of countries has been too severe in lockdown, in imposing lockdown for what he says appears to be a mild virus. So he wonders whether we should be directing our efforts to more healthy lifestyle. Diet and exercise, as obesity seems to cause more harm than COVID, and also wonders whether mortality rates for those over 70 for those under 70 are low. We should adjust restrictions accordingly. So these are major societal things that we have to contend with, and I just put it out there for views from the panel that, who wants to come in and tackle any of that.
I think it's very difficult to deal with a virus that can take everything away from one person and take their life and be and another person beside them be asymptomatic. We haven't dealt with many diseases like this in the past, and so I think as a society we will always struggle to find the right balance as to what we should do. But because we know that younger people who get the virus, who may be asymptomatic, will eventually pass it on to the elderly generation, and that's where the biggest risk is. But we have things like long COVID, and we have younger people who get severe disease as well. There's, I can't remember, is it 200,000 deaths globally now? I can't remember if that's right. That's a huge number. I don't think that's a small thing. And I don't think people are overreacting to it personally. I think we need to find the best way to react to it, and that might take some time, but I don't think it's an overreaction.
Okay, and would you say within that then that the importance of testing, the sort of mass testing approaches that we've been promoting within the NRP is one component of that way forward?
Yeah, testing is hugely important. Obviously, you know, treatments, vaccination, and testing. They would be the three most important things to try to get right. And testing will help us to try to get back to normal. But we have to really learn when to test, how to test, get the capacity high enough so that we can test regularly and allow people to lead some form of normal life until we do find some kind of solution to this problem.
Yeah, I agree with Justin. Lots of people can get this, and for some of them, it's fatal and really serious. And the scale of this, and that's tragic. You know, as someone that deals with a lot of people with very serious illness, that everyone that dies is someone's mother or father, brother or sister, son or daughter. And that's to be avoided. That's what we're here for. But not only does it do that, it consumes up so much of the very specialist resources that we have as a hospital if it gets really out of control, that it stops us doing the other things that we normally do, hip replacements, treating cancer, you know, asthma, epilepsy, diabetes, all the things that we would normally do, because we become completely consumed by having to deal with this. So this must not be underestimated. It really is. You know, we see a lot of people with infections. This is a really bad infection for a lot of people. That said, I appreciate the problem. You know, for young people, it's having significant effects on their life, school, education, university. And for a lot of people, it's affecting their ability to work and sort of pay the bills. And I completely get that. And the thing is that this is not a risk. This is what we learned early on in the hospital. This is not a risk that's carried by the individual. This is the risk that's carried by us all. And, you know, we really understand that. You know, normally the patients carry the risk in the things that we do, whether it's a hip replacement or a bone marrow transplant or whatever it is, the patient carries the risk. But for the first time, certainly in my career, the risk is being shared in the hospital context between the patient and the staff. And that's really had to be thought about. So out there, for some people, the risk is low, but the consequence economically or education-wise is high. For other people, the risk of the illness is high, but from an educational, financial point of view, the risk is low. And it's how we manage that. And it's incredibly difficult. I don't have any answers, but I can see what a struggle it is. But I would never, ever in a million years consider this to be a mild virus.
Again. So as we move forward, as we get into 2021, and we're now in a phase of increasing numbers of COVID infections going on across many parts of the world, particularly for us here in the UK as well. Really, the notion is, what are we going to do as we go forward? Are we going to? What do you guys on the panel think is going to be happening in 6 months' time in March 2021? Are we going to have a vaccine? Are we going to have more evidence of herd, what's called herd immunity? Is there going to be more levels of resistance in the population? We're going to have some better drugs and better treatments.
We'd hope we would have all those things, wouldn't we? But whether we do or not, it's hard to know. I'd say we'll have some vaccination occurring by then, perhaps some therapies, some new therapies, immune therapies, perhaps. I think one thing that is likely to be the case is that COVID will be part of our lives for maybe forever. So it's likely to become endemic. So it's probably be like the flu. You know, we will get an injection every year to try to stop it from causing infection. But you know, we will have to test for it and diagnose it, and it'll just become part of our lives. It'll probably become a seasonal thing, just like flu. Yeah, that's my opinion.
Mark, do you think there's going to be differences in the way that we deliver our health and social care and in things like care homes around do you think it's going to change any ways that we actually operate?
I was going to agree with Justin, really. I mean, it's going to be around for a very long time. I think what we're seeing incrementally is that some technology might be coming in to help us do more testing, but it comes in fits and starts. The more we see around how government works and how they need to understand a different public health approach, maybe, or different public health system, suggests that, you know, they work on a very small window as well. And so we're going to be fits and starts in terms of policy. I think you've got, you know, Michael calling in from the States. The other thing we're going to know is there's going to be a very different picture in different countries, even within countries, that you're going to see a very different picture of experience. So we're going to have more fine-tuned approaches to lockdowns and to different restrictions. And I was just reflecting as well. You know, you started talking about what changed in our lives. Well, my parents are on the other side of the country, and I normally see them monthly, perhaps, if I was lucky. This year, this calendar year, it'll be once in the year. So I think how we interact with our own families and how we utilize services, particularly where there's going to be elderly or vulnerable patients, it's going to be a very different approach. And I think we'll be getting used to wearing masks and sanitizing for a very long time.
Yeah, I'm optimistic. This time last year, we didn't know anything about this virus, and now it's about one of the most studied viruses ever. And certainly what we know now compared to it feels like we know now compared to what we knew at March is so much more. There's so much more to learn, but I do think the answer will be in vaccination. I do think it's here to stay, but I'm confident that we'll find a way. And I think as the next 6-12 months unfolds, there'll be some things that surprise us, and there'll be some things that go better than expected, and some things that don't go better than expected. But I am confident we'll find a way, and we'll adjust, and there'll be better years than this one for sure in the future.
Yes, and through the power of collaboration, new ideas will be brought to bear, and new insights will emerge, and we will be strengthened and empowered because of it. I think that's the way forward. I think what we've seen tonight is a fantastic example of how organizations and people come together and achieve more than would have been possible alone. And I'm sure that's a great beacon of hope for the future, for how we can work, how we can beat things and move onwards. I'm going to, at this point, we're coming to the end, I'm going to hand over back to Kirsty, and she can take us to the end.
Hi everybody, thank you so much for watching, and a huge thank you to our chair Dylan and our fantastic panel. We hope you enjoyed our event. Please tell us what you thought of the event by completing our survey by using the link on screen, and you can also find it on the Norwich Science Festival website. To help secure the future of our fantastic Norwich Science Festival, please consider making a donation by visiting the norwichsciencefestival.co.uk/donate website. This was the last in the series of panel discussions coordinated by the university and the Norwich Research Park as part of the Science Festival at Home programme. We hope you've enjoyed hearing about the research on our park and getting to know our scientists and medical professionals. Please keep up to date with the latest research from us by following us on Twitter. We also hope you'll join us for our next event, which is the final event of the festival at Home, which is starting at 8:30 p.m, the Big Science Quiz, hosted by Ben Garrett, Lizzie Daly, Mark Thompson and Susie Kundu. Check out the festival website for more details and the link to join. Thanks so much, everyone. Have a great evening.